Why a normal electrocardiogram and negative stress test can be misleading. Some of us are already familiar with the fact that one can have a normal electrocardiogram one day and have a heart attack next. If one did a coronary angiogram on those destined to have an imminent heart attack, 50% of the people would be normal, 30% would have a narrowing less than 50%, and 20% would have narrowing greater than 50%. In most instances, from the coronary angiogram, you could not identify the area or lesion which will cause the imminent heart attack. This is why a stress test, coronary artery angiography, cardiac catheterization can be negative and the patient still subsequently suffer from a heart attack. Even the nuclear stress test or stress echocardiogram, if positive, only identifies at most roughly 12% of those destined within the next year to have a heart attack or cardiovascular event. That means if all positive non-invasive imaging tests were treated with coronary intervention, at least 88% of those aggressively treated with early interventional procedures would be inappropriate. Wow! Assuming interventional procedures could prevent a heart attack or coronary event, which they do not, we would have to intervene on 8 people with positive functional nuclear or echo stress tests to prevent one heart attack over the next year. Can you imagine how much that costs and how much the hospital industrial complex could generate with these interventions or bypass surgery if all positive tests received a coronary angiogram or coronary intervention? Realistically, this method of utilization represents a significant fraction of that which is really happening in our United States and is why we do 50% of the world interventional procedures for approximately 5 to 7% of the world's population. Today, with the usual standard medical therapy treatment, the usual alternative to avoid any of the 12% destined heart attacks is, to our disappointment, only effective for, at best, 1 in 3. Not well known is that a coronary intervention for this group does not completely root out a future heart attack. That is, the usual culprit lesion in heart attack, or ACS, are not always identifiable by coronary angiography. These imaging and interventional procedures are, for the most part, usually nothing but moneymakers for the vendors, hospitals, physicians, and pharmaceutical companies, and most of these procedures have cumulative radiation effects. They increase the incidence of cancer. All this disease and resultant procedures occur because we and our present medical insurance system usually refuse to adequately address atherosclerosis until it becomes symptomatic. Proactive care prevention years prior to the development of significant coronary atherosclerosis would have prevented all that disease, almost all those procedures, almost all that cost, and almost all that morbidity and mortality and grief.